So welcome everybody to the Infant Mortality Prevention breakout session at the Fatherhood Summit, the Ohio Fatherhood Summit. I'm Steve Kilpack. I'm going to moderate this session today. If you can do a side-by-side screen on your computer and have our Zoom session up, and then go back into the Pathable Infant Mortality breakout session page, there's a chat there. And so we'll monitor that chat while the speakers are talking. And you can please type questions in there. And then after the speakers are through doing their opening presentations, I'll unmute everybody, and you can also ask questions that way. But so if you can do a split screen and use the chat, that would be great. So I'm going to mute participants. I don't want to mute everybody, so please mute yourselves while the speakers are going. We have 3 speakers today. First, two from Ohio Department of Health, Dana Mayer, who is the Infant Vitality Program Administrator. She'll go first, and then followed by Kay Neese, who is the Home Visiting Supervisor, and both are excellent speakers, and we're really happy to have them here today talking about this topic. And then that'll be followed by Calvin Williams, who is the Fatherhood Coordinator with Hamilton County Job and Family Services. So Dana, you want to kick it off?
Oh, man.
I would love to. Good morning, everyone. As Steve mentioned, my name is Dana Mayer. I'm the Infant Vitality Program Administrator at the Ohio Department of Health, and just want to say thanks for the opportunity to be here. Happy Thursday. Excited to be spending it with all of you. As we kick off today's conversation, I was thinking maybe we could start with the data. Really use the most recent data, which is lagged, of course. Hello, Public Health. From 2018, our infant mortality data as a way to really ground and guide our conversation for today. I suspect many of you in this conversation are very familiar with Ohio's infant mortality statistics, and particularly the racial inequities in birth outcomes that particularly our moms and babies in our Black population experience. And I also recognize that this isn't new for the vast majority of you, and many of you have been fighting tirelessly in this effort for decades. And so I first want to say before I get started, thank you to each and every one of you. What you do each and every day for fathers and families matters, and it is absolutely part of the comprehensive package of services and interventions and supports for our communities that we need to invest intentionally in and strategize around to really reduce the poor birth outcomes we're experiencing, particularly for our Black mamas and babies. So truly excited and grateful to be here and for the opportunity to learn from and with all of you. That's really what I hope to get out of today. First want to say the data I'm sharing can all be found in our ODH data documents, which are in our virtual booth. So shameless plug, come visit us later today, download all of our resources. We also have lots of resources for fathers and families across many of our programs. So you can find those all in our virtual booth. And I just want to preface, I'm going to admit ODH maternal and child health has a strong base of evidence for serving women prenatally. We know if we get mama connected to services while she's pregnant, we can impact poor birth outcomes. And with that said, I'm sure many of you are aware, our programs primarily focus on women prenatally. However, I think it's important for us to recognize historically, the bureau that I'm in at the Ohio Department of Health has been called the Bureau of Maternal and Child Health. However, in recent years, we changed that to the Bureau of Maternal, Child, and Family Health. And I think that just honors and recognizes the incredible importance of fathers and families and an entire support network to ensure healthy pregnancies for our mamas and healthy lives for our babies. And so I hope today that Kay and I can learn from each of you how to better incorporate fathers and families into interventions and strategies that maybe often focus directly and solely on pregnant women. I think there's a lot of opportunity for growth and enhancement, and we look forward to you all as experts to help us think through what that could look like. Next slide. So let's ground ourselves in the data. What is infant mortality? I want to start with the definition. Infant mortality is the death of a live-born baby before his or her first birthday. And infant mortality rate, which you'll also hear us refer to, is the number of infant deaths per 1,000 live births. Also, you'll hear me say IMR a lot. When I say IMR, I'm just using my shorthand for infant mortality rate. So that is that rate of deaths per 1,000 live births. And as all of you know, infant mortality serves as a key indicator of not only maternal and infant health, but the importance of being a measure of health status in our communities. Not only does it talk about the wellness of our moms and babies, but really of the overall health of that community. Ohio's overall infant mortality rate in 2018 was 6.9 per 1,000 live births. This was down from 7.2 in 2017. From 2009 through 2018, Ohio's infant mortality rate has decreased about 1.1% per year. So we are seeing a downward trend, but I don't have to tell all you, we have an incredible amount of work to do. However, the overall rate remains above the Ohio and national goal of 6 or fewer infant deaths per 1,000 live births in every racial and ethnic group. So in 2018, our white IMR was 5.4, which was pretty similar to what it was in 2017 when it was 5.3. And after 5 years of increase, our Black infant mortality rate in 2018 was 13.9, down from 15.6 in 2017. So progress, always want to celebrate our progress, but also want to caution folks that 1 year of data doesn't identify a trend, and that we can't let off the gas. And even if 13.9 is an increase, it's still absolutely unacceptable for our Black communities, our Black mamas, our Black babies, and Black babies are still 2.6 times more likely to die than their white counterparts. And it's absolutely not okay. And so I thought today maybe it would be helpful for us to really target our conversation about those racial inequities. Next slide. And talk about what did we see? Why do we think we saw that decrease in Black infant mortality? And so what we will unpack is the lower number and rate of neonatal deaths that we saw, particularly for Black infants, and the decrease in prematurity, particularly those extremely preterm births, which were those babies born before 23 weeks gestation. Next slide.
Oh, she wanted to make.
We generally, in the data world, organize infant deaths in 2 categories. The first being neonatal deaths, and those are all of our babies who pass in the first 27 days of life. And then that second category is what we call post-neonatal, which occurs at days 28 through 364 days of life. Neonatal deaths, so those really early deaths, are the largest contributor to the overall infant mortality rate, accounting for about 2/3 of all infant deaths. These are most often our premature and extremely premature babies, which makes sense. You know, I will talk a little bit more about how gestational age is highly related to infant vitality. And the difference in the overall infant mortality rate from 2017 to 2018 can largely be attributed to fewer neonatal deaths in 2018 compared to 2017. So we saw a drop in these babies who were passing before their first 30 days, technically 28 days of life, last year in 2018. And this is especially true for our Black babies. It's likely due to a drop in premature births, especially those extremely premature babies. We had fewer Black babies born prior to 23 weeks gestation in 2018. The neonatal mortality rate for all races in 2017 was 5.0 and 4.7 in 2018. However, the Black neonatal mortality rate in 2017 was 11.3, and as you'll see on your screen, dropped to 8.5 in 2018. So I really think we need to take this opportunity to try to understand what was different about this year and how do we replicate that. Next slide. And as I had mentioned, and as you can guess, infant survival is highly associated with gestational age. Although infants born less than 24 weeks, those super early babes, accounted for only 0.3% of all infants born. So a very small proportion of all babies born in the state. That 0.3% of infants born accounted for about 1/3 of all infant deaths. And most of those occurred during that neonatal period within the first 27 days of life. Despite the same proportion of babies being born full term. So what full term means to us is that baby's baked for 37 weeks and is likely full and healthy and able to thrive outside of the womb. While we had the same proportion of babies born full term in 2018 and 2017, the proportion of term babies dying was higher in 2018 than in 2017. So we're really trying to understand, why is it that we saw a decrease in those extreme premature births in 2018, but an increase in those full-term babies experiencing more infant deaths? Next slide. Talking a little bit about prematurity, from 2009 to 2018, there was not a significant change in our preterm birth rates, not for overall Black or white. The white preterm birth rate did not change from 2017 to 2018, and the Black preterm birth rate went from 14.4% in 2017, small drop to 13.8% in 2018, which may have contributed to the difference in the Black neonatal mortality rate and Black infant mortality rate. So really trying to understand the data to think about where are those opportunities for intervention so that we can prevent our communities, particularly our communities of color and parents, from ever experiencing these infant deaths. Next slide. Wanted to talk a little bit about causes of death. What did we see in the 2018 infant death data? We saw that prematurity and congenital anomalies together accounted for half of infant deaths in 2018. What does congenital anomalies mean to you? Birth defects is what they're most known as. I share this chart to say, we see where the infant death causes are occurring. And while in many cases is incredibly challenging and sometimes not something we have are able to have an impact on, we oftentimes can intervene before a preterm birth exists. So how do we strengthen and improve our efforts aimed at reducing and preventing prematurity, particularly those extreme premature births, so those babies that are born before 23 weeks? Next slide. Where is it that fathers are formally, for lack of a better phrase, incorporated into ODH programming as a basis for you all helping us think through how can we do that better? So wanted to highlight 3 of our programs. Cribs for Kids is our safe sleep education program. It offers free cribs to families along with safe sleep education on how to ensure babies are sleeping safely through their first year. And dads are eligible for cribs and safe sleep education. This isn't something I feel like a lot of folks know. We just presume that the resources are available to moms, and we need to do a better job as providers of these resources to ensure that everyone is educated about the availability of the resources. And in some programs, I actually did not know this myself when I first started. In some programs locally, parents living in separate households can actually both receive a crib. So even if there's shared parenting, many of our Cribs for Kids programs allow a free crib and education to both of those households. Moms Quit for Two is our perinatal smoking cessation program. One thing that's really cool about this program, because we know how important a smoke-free household is to the well-being of a healthy pregnancy and a healthy baby, a support person living with the pregnant mom who is receiving the smoking cessation services is also eligible to receive free smoking cessation services and incentives. So not only mom, but a support person in that household. So perhaps dad would be interested in receiving resources and incentives to help him quit smoking while mom's pregnant and postpartum as well. And third, Wic, I'm sure many of you are very familiar with Ohio Wic program, but when a father has custody and meets all the other required eligibility requirements, they too are eligible for Wic benefits. I don't know that this is something that we often talk about or leverage or promote, but definitely worth noting that dads do have access to Wic benefits and being thoughtful about how it is that we make that connection more clear. Next slide. And today I just challenge us, or I ask that you all challenge me, maybe is the better way to put that, as we think about ways to incorporate fathers and families more comprehensively into infant mortality reduction activities. One thing I was thinking through is as you'll see on this slide, we did a deep dive of the 2018 infant death data, and we identified some key themes where preventable risk factors for infant deaths were common. And so I thought, what if we really focus our ideas around thinking through where can we better incorporate dads and families in some of these common themes that could have maybe contributed to a prevention of a poor birth outcome or an infant death? So some food for thought: how do we ensure fathers know and understand the importance of safe birth spacing? How do we make sure that he's equally as aware as mom that 18 months between pregnancy is healthiest for mom and baby and can help ensure a reduced risk of preterm birth? How do we empower dads to promote moms' early access to prenatal care? We know if women access prenatal care in their first trimester, the data says that she's more likely to have a positive birth outcome. How do we help dads be a part of that process to empower and encourage moms to access their prenatal care early? How do we educate our dads and our families on the role secondhand smoke plays in poor birth outcomes? As I had mentioned before, we know household smoking, it's not just about that mom being a direct smoker, but in fact, her environment definitely impacts her well-being and the well-being of her pregnancy. How do we ensure proper family and life planning resources for both young women and young men? And once again, ensuring that we are effectively communicating resources where available to our dads throughout the state. And so with that, I'm really excited for today's conversation. Again, look forward to learning with and from all of you. And with that, I will pass it along to Kay to talk about ODH's home visiting efforts.
Hello, everyone. Thank you for being here with us and for having us come to talk to you about the programs at Ohio Department of Health. My name is Kay Neese. I am the home visiting supervisor. So I'm working with all of the home visiting program models administered through the Ohio Department of Health. And collectively, that group of programs is referred to as Ohio's Early Childhood Home Visiting Program. It is a collaborative partnership at the federal, state, and community levels. And the overall goal of the home visiting system is to improve child and family outcomes. We do that by implementing evidence-based home visiting models that have a strong data and research base to show that they do in fact improve outcomes for moms and babies and families. The system includes several components: central intake and referral, the Help Me Grow home visiting component, which is state funded and is the largest part of the home visiting system, maternal, infant, and early childhood home visiting initiative. We've referred to that as MCV, and it is a federal program through HRSA, Human Resources and Services Administration, and the Black Infant Vitality Program, Moms and Babies First. And that program also receives federal funding through Title V. Next slide, please. The goals of early childhood home visiting are to improve maternal and child health, prevent child abuse and neglect, encourage positive parenting, and promote child development and school readiness. Next slide. There are 4 models, evidence-based and evidence-informed, that are implemented through the Ohio Department of Health. And they are all working on those goals. As Dana mentioned, we know that a healthy birth outcome is tied to women's health. So these programs do focus quite a bit on prenatal health and both women and infant health. They differ slightly in their models, but primarily it's around eligibility criteria and the length of stay in the program. So nurse-family partnership and Moms and Babies First require that the woman enroll in the program while she's pregnant. And so they are really focused on birth outcomes and ensuring a healthy pregnancy, a healthy mom, and a healthy birth. Healthy Families America and Parents as Teachers also try to enroll during pregnancy, but can also enroll early in the infant's life. And those 2 programs stay with the family a little bit longer than Nurse-Family Partnership and Moms and Babies First. Next slide, please. Eligibility for home visiting in Ohio in the programs that are implemented through Ohio Department of Health is established in rule. So that means these criteria are part of the Ohio Administrative Code. So currently, eligibility is determined first by financial eligibility being at 200% of the federal poverty level or lower. And then in addition to that, at least one of the risk factors on this list here, pregnant and less than age 21, previous poor birth outcome, history of child abuse, neglect, or involvement with CPS in any way, a history of substance abuse or a demonstration of a need for treatment, use of tobacco products in the home by any family member, a child with a diagnosed developmental delay, active military duty, history of unstable housing or homelessness, and caregiver with a history of depression or other mental health concern. So that can either be the primary caregiver or another caregiver in the home. Next slide, please. One of the things we are working on is to change the home visiting rule. The changes that we're proposing will likely touch every part of that rule, but significantly we're working to be more comprehensive and inclusive in the eligibility criteria. So we anticipate some big changes there over the next year with the goal to serve more families. There are many families waiting on the waiting list that desperately need the support of a home visitor and would be eligible if we could open up our eligibility criteria just a little bit. So we are working toward that goal. We do serve eligible fathers who are the primary caregiver. We have a partnership with Bridges to provide home visiting services to young fathers, and they don't necessarily have to be directly connected to that baby at the point they enter the program. I will say we looked at our data and we've not had a very robust referral process with that program, so there's an opportunity for us to strengthen that partnership and work a little closer together, do some outreach so that we are making sure we're connecting with those young dads. We are on a journey to be more inclusive of fathers in this work, and we're open to your suggestions, your ideas. We know that having fathers in a child's life has an impact on their school readiness, on their social emotional well-being. We know that dads who are involved in a positive way prenatally with prenatal visits and just supporting safe sleep and other initiatives have a positive impact for families and babies. So we did look at a little bit of data around fathers in the home visiting programs. And this slide talks about, let me get my notes up here. Okay. These are looking at across all models and then separated out by models. This shows the percentage of home visits attended by fathers among family members where there is a record of the father in the family, in our data system. So that means if this does not include, there may have been a note that a father was present at a visit, but if we do not have them entered as another caregiver in the system, then we didn't pick up on that data. So it tells us that we do have perhaps some data gaps, and there is an opportunity for us to just work on making sure that caregivers are identified consistently so we have a record of where fathers are involved. So let's see, I want to go back up to the, okay. Across all models, out of 10,765 families enrolled in state fiscal year 20. So that would have been July 1, 2019 through June 30, 2020. We had 86 families with fathers identified as the primary caregiver and 1,849 families with fathers listed as caregivers on the family record. And again, this number may be a little lower. We have an opportunity there to make sure that we are gathering better data about fathers being in the household and making sure that that is entered in the database. And then next slide, looking at the percentage of home visits attended by fathers. So across all models, it was about 30%, just a little bit above. You can see a slight difference in the models. Healthy Families America and Parents as Teachers tended to report more father participation in the home visits. Again, Moms and Babies First and Nurse Family Partnership are really focused on maternal health and a healthy pregnancy. So they're focused on prenatal education and making sure that mom is attending all those visits. There's probably a gap in the data here so that home visitors are more focused on the data entry they're doing around the prenatal education. And so again, we have an opportunity there to make sure that we're reflecting the whole picture, capturing that in our data, and reporting out when fathers are present for these home visits. So 30%, I think, is a really good start, and we'll continue to work on engaging dads and including them in the home visits. We use two curricula, Growing Great Kids and Partners for a Healthy Baby. Both of those curriculum models include dads and have materials specifically directed towards fathers. So we'll continue the work and are encouraged by this conversation and really want to hear from you how we can do better. Thank you.
All right. Thank you, Dana and Kay. And thanks to both of you for being so open to having a conversation today about including fathers in your programs. So we're going to shift now, and there is the information for Kay and Dana, which also should be in your program booklet, I think, if people want to contact you. So we're going to shift now to Calvin Williams. He's the Fatherhood Coordinator for Hamilton County Job and Services. And Calvin, you ready to unmute and start your presentation?
I'm ready to go, Steve. Thank you.
Right. Yep.
All right. Thank you so much, everybody, for participating in this breakout session. I'm Calvin Williams, Fatherhood Coordinator with Hamilton County Job and Family Services. And I'm also a founding Wisdom Council member of Reaching Our Brothers Everywhere. Reaching Our Brothers Everywhere is a national Black men's breastfeeding and infant mortality organization. Reaching Our Brothers Everywhere, or ROBE, is also a partner with the Hamilton County Fatherhood Collaborative. So we're very fortunate to have that type of expertise and connection to this issue right here in our own community. Next slide, please. So some of this data was already presented, but I just wanted to underscore the issue in terms of infant mortality for African Americans. This is some data from 2017. And if you look at the causes of death and you see under low birth weight, the number of African American deaths reported that year, and the death rate versus non-Hispanic white deaths and that birth rate, it's pretty extreme. So low birth weight being a #1 cause of infant mortality, and low birth weight can be attributed to a number of factors. But one thing that is continuing to present itself more in the literature is stress and racism. Okay, and these are areas that, and we'll talk about it later, and hopefully we'll have some questions about this too. But these are areas where fathers can come in and play a pretty significant role in reducing the impact, in reducing stress and the impacts of racism. Okay. Next slide, Steve. So this is some research that just kind of hit the press. It's been out there for a couple of years, I believe. But Black infant mortality and Black doctors. The research studied 2 million birth records in Florida, and from I think 1995 to 2017, I believe, 430 more fatalities per 100 live births when infants were born under the white newborns experienced 430 more fatalities per 100,000 births. Black newborns in the care of Black physicians had 173 more fatalities per 100,000 births than white newborns. That's incredible, okay? That's an incredible finding. And they also found out that Black newborns are especially likely to survive when cared for by a Black physician at hospitals that deliver more Black babies, okay? So this research, like all research, just leads you to more critical thinking and questions and what the next level or depth of research is needed. And certainly this isn't indicating that white doctors have some malicious intent with regard to caring for Black babies. It's more indicative of the structural issues in healthcare, okay? But you really want to talk about putting a shining a bright light on those structural inequities. This research really did the job there. Next slide, please. So infant mortality mitigation and prevention as it relates to fathers. There's some qualitative research out there that states when fathers are involved during pregnancy, maternal negative health behaviors diminish and the risk of preterm birth and low birth weight and fetal growth restrictions is significantly reduced. Fathers have a huge role to play in this issue. And some of the thinking is when fathers are involved during the pregnancy, they're going to be a cheerleader, an encourager, somebody who's going to be checking on mom, challenging mom, to supporting mom to do the things that they know are going to be healthy and helpful for that pregnancy and for a full-term delivery. So fathers, and we'll talk about this further in our discussion with you all, but there are a number of things fathers can do. And I think one of the big things is helping fathers understand their value. When you work in fatherhood, and for those of you in the breakout room who have worked in fatherhood for a while, you understand that that is an area that men really struggle with, and it's not their fault. They struggle with seeing their value as a father. They see their value in the family. And one of the things we want to help men understand is that value doesn't start when you start buying those cute little Nikes. That value doesn't start when you are paying child support or those type of things. Your value starts early. And that's what we want to help fathers understand. Next slide, Steve. Now, we're going to talk about breastfeeding a bit, because the research is clear that when you target fathers in breastfeeding promotion, and that's interesting, right? Just targeting the fathers in your promotional efforts around breastfeeding is associated with 2 times the likelihood of getting the baby exclusively breastfed for 6 months. Why is that important as it relates to infant mortality? Is because breastfed babies have about a 50% less chance of dying from sudden infant death syndrome and other issues. Breastfed babies, the breast milk has properties that actually preclude a lot of health situations with infants and really ensure that you have a really healthy first year of life. The World Health Organization recommends exclusive breastfeeding for all babies for at least 6 months, and then the introduction of complementary foods from that point up to 2 years, right? So breastfeeding is a definitive infant mortality prevention and mitigation effort. Okay, go ahead, Steve. So when fathers are educated on breastfeeding, Due to their support, better positioning and attachment of the baby to the breast during feeding would be facilitated. Why is this important? Because the research shows that most moms who end breastfeeding at around 2 weeks do so because of lack of confidence and because of issues with breastfeeding, such as pain, that can be managed with proper care and support. And so if the breastfeeding initiation happens, but the duration is only 2 weeks, then there's less of a chance of the mom and the baby getting the benefits of the breastfeeding experience. So getting fathers targeted for breastfeeding promotion, getting fathers educated on breastfeeding is going to help mom and baby in that breastfeeding experience and help the family achieve their breastfeeding goals, which is going to mean healthier infants. And listen, we're talking about breastfeeding or skin to skin and that infant's initial attempt and effort at breastfeeding at birth. And too many fathers don't understand the implications, and so they're not able to advocate for mom and for their families in the labor and delivery setting to say, hey, when my child is born, I want my child skin to skin with mom for at least the first hour so that child can do what they're naturally and instinctively able to do, which is make their way to the breast and get the early experience of suckling, right? And in that same vein, we need fathers in that labor and delivery setting to go skin to skin with their babies as soon as it's possible in that setting. So mom for at least the first hour and putting that baby skin to skin somewhere on the stomach or midway between the stomach and the chest, let that baby root, crawl, and leap towards the breast. The baby knows what to do. But in too many labor and delivery settings, fathers aren't able to advocate for that because they don't know that, right? I'm actually coaching a couple right now who is due September 18th. And I was so excited. I actually had a coaching session with them about a month and a half ago, and I visited them yesterday. I was so excited. They have their prenatal visit coming up. It's really, really close. And they said, we're going to be talking about our birth plan. And that really made me feel good because that's what I taught them, is that you can decide what the plan is for your birth. In other words, in that labor and delivery setting, what happens after the baby's born? Do they whisk the baby away? Do they dry the baby off? No, you don't need to dry and clean and weigh and pick and prod the baby. That first hour belongs to that baby, mom, and dad, right? So the breastfeeding is a huge factor in this infant mortality issue. Fathers are a huge factor in whether or not moms decide to breastfeed, initiate breastfeeding, and breastfeeding duration. Next slide, Steve. I think that's it for me.
That's it?
Yep, good. Well, let's get to the people.
All right. So I'm going to stop sharing. And we have about 30 folks. So I would suggest that we can have a nice conversation by everybody turning off on their video and raising your hands. And I'll call on somebody with a question or a comment. We did have one question while you were speaking, Dana, and I think it's a question for you and Kay both. And it's really, how can community agencies partner with the Ohio Department of Health programs? You want to take that, Dana?
Sure, I would be happy to. So ways that community agencies can partner with ODH programs. The way that we currently structure our program delivery tends to be through a sub-grant relationship. So we fund local community entities, oftentimes local health departments, but many other cases, local nonprofits, maybe an educational institution, to really deliver those services. Because one thing we recognize is we have so many limitations at the state, and being able to tailor and design interventions that are responsive to the needs of the folks that live in your community is something we would fail miserably at. So one thing we try to do is create a model that allows us to ensure that local partners are able to deliver our evidence-based programming, and even some of our programming that maybe isn't evidence-based, but we know has a base of evidence that's not yet formally approved for improving birth outcomes. moms, and really just trying to be thoughtful about how is it that we create mechanisms that give you all enough flexibility at the local level to design, tailor those strategies in a way that's truly responsive to the needs of your community. Because what I need where I personally live in Fayette County is going to look very different than what a mom needs maybe in a very urban setting in downtown Cincinnati, which is going to look entirely different than Grove City just outside of Columbus. So working really hard to be thoughtful about how do we support you in really funding those of you who are best suited to do this work, because I will admit in many cases it's not us. And then giving you all the flexibility and information to connect with one another so that you can reach more moms and babies locally.
Great. Thank you, Dana. So I see my friend Sandy Hoke is here and she's unmuted herself. So I'm going to guess she's got a question or a comment.
Oh, no, I didn't. I was just listening.
All right.
Hey,
Calvin,
Steve.
it's good to hear you, though. You did an amazing job.
Oh, hi, Sandy. Good to see you.
Good to
Thank
see
you.
you, too.
Thank you.
Calvin,
Hey,
you
I
have a
just-
thought? Yeah.
Yeah, I just wanted to point out, I forgot to mention that I am a certified lactation consultant. Just
For
so
you.
some of the guys on the phone, or some of the people on the phone might be, why is this guy talking about breastfeeding? Because I live it, okay? And I'm committed. Once I became a lactation consultant, it became a new passion that blended with my passion for serving fathers. So breastfeeding and fathers is at the cutting edge of fatherhood practitioner work, okay? Because it's like not only life-saving, but the health implications for the life of the child are too strong for families who choose to breastfeed. And I want to make sure the key word there is choose. There's some pushback against breastfeeding because people think people are being guilted or shamed or forced into breastfeeding. What we want to emphasize is breastfeeding is an infant feeding choice, but if we want to educate families to make the choice that's best for them and for their baby. So just wanted to make that point.
Thank you, Calvin. So I want to put out a question to the audience. Dana and Kay made a clear request in their presentations to partner with the community about more father inclusion in their programming. And it would be great, I think, to get some fatherhood practitioners' responses to that, how ODH programs can be more father inclusive. Raise your hand and unmute.
Can I answer?
You can, while these other guys are thinking.
Yeah, so what comes to mind for me is a stronger, more vibrant connection between ODH and the Ohio Practitioners Network for Fathers and Families. And I know, Steve, you've done a good job of building some of those relationships and advocating for fathers in this space. But I think there's an opportunity for ODH and the Practitioners Network, which represents over 1,000 people in the state and hundreds of practitioners, to be able to continue an ongoing dialogue about this. Because what's important for fatherhood programs is to inculcate this into the program, right? Not enough fatherhood programs are talking about this issue. It needs to be standard, and working together, we can figure out how to do that.
Thanks, Calvin. So I'm going to go to Ron White and then Tim Greenwood.
Hey everybody, how you guys doing? I would just suggest to take advantage of some of the programs that's out here that are working and doing that work. What Mr. Williams was talking about is kangaroo care, and we have been pushing that in all our major hospital systems for years now. And through one of the programs that I work for, and there's others, but Boot Camp for New Dads catches men for the first time that's having a child, and lets them know how important that is, and in detail, and how to walk through it and how to advocate for themselves in that situation, like you said, to make sure that you are participating in kangaroo care, because it's so important. So there's programs out here. I don't believe in reinventing the wheel. I believe in paying attention to the programs that's out here doing a great job, and actually promoting them and learning from them, and just networking with them.
Thanks, Ronald. Tim Greenwood, you're on the phone. You want to unmute and share something?
Hear me?
Yep.
Awesome. Hello, everyone. I think a big opportunity would be to, like Ron said, engage with these community partners who are out there doing the work. And we're not seeing as much, I guess, feedback from ODH, where we're seeing funding going into different areas where it could be used to help those community partners to actually engage. A lot of people aren't getting the resources they need in order to get into the community. A lot of the resources recently were shifted towards more of the centering process and also the home visits, but it wasn't really engaging with dad or figuring out how to get dad involved. So what we really need to do is find a way to kind of support these community agencies in order to get into the communities and help the people that actually need the help, as opposed to focusing specifically on centering and home visits, where we are seeing a lack of father engagement. As you see, I think it was at 30% or so. So that's what we really need to try to focus on. And that partially comes with funding from ODH and then those grant processes and awarding processes.
Thanks a lot, Tim. You got some thumbs up and nods here. So we're going to go to Michael Newsom, then Robert Cummings, and then Sandy.
Good morning. Thanks, Steve. I'm Mike Newsom, Fatherhood Director in Montgomery County. We've been fortunate to receive a grant through the Ohio Department of Medicaid. Actually, Public Health received it, that had to do with infant mortality, of course, and we were able to weave in a program called Every Parent Matters, which I supervised the 3 guys. And those guys have done a tremendous job of home visiting, which until this point really had only been for moms, quite frankly. And we've actually moved the needle on our infant mortality numbers. And I think that's been a great reason why. It's because of the early engagement of fathers, not only with them dealing with health issues, but also just helping the fathers get to a point where they are comfortable and feel, to the point earlier, the value that they have and are able to get employment and get this stable housing and all those things, because obviously fathers can't be of assistance if they're not in a good place themselves. So we've been able to, I've been the Fatherhood Director in Montgomery County for 10 years, so we're very fortunate to have someone within the system that, has that position. So we're set up perfectly to help fathers, not only do well, but be a great assistance to the mothers. And so, I just want to piggyback on everything that everybody said. I really think the home visiting piece, which quite frankly, I was not overly familiar with, not having, I actually work for the county. I don't work for public health, but, I wasn't as familiar with that, how important that can be. And so, it's just great to have 3 males to be able to go out into people's homes pre-COVID, of course, and be able to, to interact with the fathers and let them know, to Calvin's point, your role starts now. When mom's pregnant, it doesn't start after the baby's born. And, we're telling you to establish paternity and pay child support. It's much more than that. So, again, to Ron's point, please check out our program. And, we'll certainly be happy to give you any information we can and discuss how we can, make it go throughout the state.
All right. Thank you so much, Mike. So Robert Cummings.
Yes, good morning, everyone. Having a community of folk around me and around our program, being a part of the Fatherhood Collaborative of Hamilton County, having those individuals to instruct and give you guidance on engaging fathers is crucial. Not only, and also our agency being a Head Start program and being governed by, the state, the feds, and having legislation that we must follow also helps. The guidelines are already there for us as being a Head Start, having a pregnant moms program, a home visiting program, and just being a resource and a listening ear for a father. I'm glad to hear that there are, the Wic Program, how they are encompassing fathers, that we can go to them. Getting that information from Dana was crucial for me. We also have, just 2 weeks ago, we had a program with our Cradle Cincinnati outside of Community Action Agency in Cincinnati, Ohio, where we had the fathers from the Fatherhood program, basically set up everything and greet dads that came in with their pregnant moms to get the safe sleep, to do the study, and to receive that pack and play and that crib. So it's moving the needle, but it's so important that we really flip our minds and understand the ideology that fathers do matter. Without that father being engaged in that household, we will not move this needle. So I'm so important for Robe, reaching our brothers everywhere, reaching our sisters everywhere, these people that deal with African Americans, and understand that we have to see our own and be able to govern them and be able to have those frank talks, to be one-on-one with them, to understand these fathers, to be able to touch them and be able to trust the fathers, be able to trust the information that they get. So I am so excited. I'm happy that I got this information. Mike, you were on point. You did a great job at understanding the plight of fathers and what they go through, the barriers that they face. And man, thank you guys for everything. But I'm glad that I got this information this morning. I wish I had some more people from our agency online with this call. Thank you.
You'll be the champion, Robert. You can count on
Yes,
that.
sir.
All right, Sandy Hook.
So I had a question and a statement. One was I wanted to make sure that people knew, at least in Cuyahoga County, because we're following the path to baby friendly, and because we at Metro Health are trying to reach the Ohio Department of Health's 5 stars for healthy babies for breastfeeding, you have to have 80% of your mothers and families in kangaroo care in the first hour of life. It's a requirement. So most of the Cuyahoga County hospitals are doing kangaroo care. I just wanted to let people know, and I'm sure it's like that everywhere across the state because of the ODH First Steps program. We've made great strides over the last 5 years because of that. So I just wanted people to know it's actually mandated if you're on that path, and it's being accomplished. The question that I had was for the ODH folks. It is September, so do we not have 2019 data to report by now for infant mortality?
Sadly, no. So our death files, coroners have 6 months to finalize reporting. And so we aren't able to usually even close our vital statistics death files until early July. And then that period of time for analysis and unpacking and getting the reports out. So we are working on our annual Ohio Department of Health infant mortality report. Last year, I will be completely candid and transparent with all of you, it was late. And we are working diligently to get that out. Our goal, I think, is October, November. Don't hold me to that. But definitely our folks have been working really hard on the analysis. We're always super lagged, but we can do a better job too, making sure that we get it out as quickly as possible after those death records close and we have a chance to analyze it. So coming, but lagged.
So Cuyahoga County's data is in now. They still had some two deaths, I think, lagged for safe sleep. So they kind of analyze along the way a little bit starting in July so that they're ready to go by August, and then they reboot if they have the late things come in. And part of that is the pressure from First Year Cleveland to make sure that we can move more quickly on our infant deaths. So do you think the state will come to that?
So we're really lucky too to have our partners like First Year Cleveland and Cradle Cincinnati and Celebrate One, as long as all of our other infant mortality local efforts who push us equally. Like, well, if we can do it locally, friends, why can't you all help us figure it out? And so we've been working towards establishing a preliminary report annually. So recognizing, you know what, this data isn't valuable if it's stuck behind a bunch of doors that our locals can't access to use to inform their programming. So thinking through, can we on an annual basis issue a preliminary report that then can be followed up with a confirmed annual report? And I know that's something our data team's working towards. I don't think it's going to happen this year, but I think it's a really important point that you make, that we just have to do better. And there are ways to create processes that support us in doing better. And that's one idea I know that we're working towards.
And then my final question is for home visiting. Has anybody at the state looked at the data separately since COVID to see if more people are home and working from home, and has that increased father participation?
Good question. I don't think we have looked at father participation during COVID. So that's a question I'll take back and see if we can look at that data again and pull out that detail. We have been looking closely at home visiting participation since March, since we suspended in-person visits.
Mm-hmm.
And what we have seen in general is that families have stayed engaged. The number of visits has actually increased. The length of the visits has decreased a bit because there are just some technical challenges to video and phone visits. We've stayed engaged with families longer, meaning that families have not exited out at the same rate when compared to the same months in 2019. So we've learned a lot with this experience of virtual visits, and likely will retain that virtual option to support staying engaged with a family, and maybe make it easier for families to stay engaged with home visiting. We are also trying to assess where there may be some gaps and where we need to do some work to support access. We want to make sure that we are not leaving behind any vulnerable families, and concerned that in this world where we are still recommending exclusive virtual visits, we don't want to lose any families because of access issues and difficulty with technology.
Mm-hmm.
But I will take that question back and see if we can tease out dad involvement. Again, that data was from fiscal year 20. So it did include data from COVID. I just don't have that data for those months looking at dad involvement. So I'll take that back. It's a good question. Thank you.
It would be also nice to know going forward, if we go back to in-person visits, that we could include dads virtually, since we're used to virtual visits, if they can't be with the family at the time.
That's a great idea too. Yes. Some combination of that. Yeah. Encouraging that involvement in any way we can. That's, yes.
Thank you.
Jane McEwen has her virtual hand up. So I think she's got something to share or say.
Yes, I do. Thank you, Steve, and thank you to the presenters. Excuse me. I wear a couple of hats, but the one that I'm representing, I'm also the manager of the Mentoring Collaborative of Montgomery County under Sinclair College. But I also am wearing the hat. I started a Teen Moms program right in inner city Dayton years ago called Pals for Young Moms. It was birthed out of Omega Teen Moms, out of Omega Baptist Church, and we changed the name to Pals for Young Moms. We did that for about 8 years, and so me having been a teen mom, was pregnant, and at 14 delivered my child at 15. And although I have a lot of accolades in the success of my career, I know what worked for me. And one of the things was family, the church, and a support group. And support groups I started because of that. The Pals for Young Moms has branched off many of other support groups that are now existing in the county from that idea and that concept. But now I'm working with Dayton Urban Young Lives, which is a teen mom support group. I'm consulting and developing and training other programs to do this same concept. And one of the things, I've helped hundreds of moms throughout, and a lot of them are in college now. The babies are in college, to tell you how awesome that experience was. But I know it works when you support moms, but you also, I know when the support of my baby's father, what that felt like for me. And so the girls said to me, Miss Jane, why don't we get the fathers involved? And so we tried to do, at that time, we're talking 2008 and 9. And so that tells you how a while ago that was when I did PALS. It was hard to get fathers. It's hard to get men, first of all, and even in the mentoring world, it's hard to get men in a group. It's hard to get men to assimilate in those personal ways. So I really commend, especially you, Calvin, for what you're doing in working with the males. So I highly suggest that we launch the Dayton Urban Young Lives support group for teen moms. It's virtual. We meet every other week and we deliver food to the girls. We meet them. The challenge is the technology divide is huge in the city of Dayton. Our girls are in inner city Dayton. We're looking at ways to partner better. We're just starting. We started in June. So I know about partnerships. I know about connections. I know about the services throughout Montgomery County. I'm very well connected in that area, but I'm coming back though. So I want to know, how can I work stronger in providing services? I'm right across the hall from Help Me Grow. So I know about all the great services that we have. So I'm reaching out. That's one of the things I'm saying. But I'm also saying I want to work with the girls, the mothers' fathers, because I know, as you reported, that's huge in the success of reducing infant mortality. Getting those fathers involved, those relationships. Mothers, when they're pregnant, and teen moms especially, are under an incredible amount of stress, not to mention the pandemic, right? So we really, we're dealing with a mom right now who is, has to make a life or death decision about a loved one and is pregnant. And so that's hard. That's very difficult. So support groups work. And I'm really encouraging more of those. Fathers, especially virtually, is a great time to do that. It's not an excuse to not do anything. And so we're doing it and it's working. And so our numbers, I know we could probably have 30 girls a week, but we're growing slowly. I'm not about numbers as much as I am about accountability and managing it right. So,
thank you so much for your compassion, Jane, and passion. Calvin, do you want to take that and talk about some father engagement strategies for someone like Jane?
Sure. And I've been listening to you, Ms. McEwen, and thank you for your remarks. One thing that's not talked about a lot around father engagement as it relates to maternal child health, pregnant moms, et cetera, is the couple relationship. And I know that, in the work that I've done, the quality or the status that the couple relationship is a big factor on whether or not that father is going to be engaged in the work. So thinking about dads and helping them identify, be clear about their relationship with mom and their goals for mom and the baby is a good way to start engaging dads around that. Moms themselves have to, some of the research talks about that the two biggest factors for dad's involvement during the pregnancy is mom's idea or conception of fatherhood and the couple relationship. And so when we talk about fatherhood education, that has to go to moms as well, because there are too many moms, especially young moms, who have unrealistic expectations or conceptions about what a father is and what a father should be doing. Now, of course, they'll be colored by their experience in their own family, so they could be at a belief level, but understanding the father's transition during the pregnancy and transition into fatherhood is really important for moms, even fathers, to really have them think about this transition, because some of the literature talks about fathers really don't even consider the child real, so to speak, until the baby gets here. And so fathers are going through a transition that has discernible points in it, and we need to be able to engage them about that as well. Not just the idea that, okay, your wife or your significant other is pregnant, so just do what you're supposed to do, right? The idea is, no, they need that care and that attention to their own transition into the fatherhood role. Moms need education on fatherhood, and then moms have a role to play to invite dad into that space.
You're absolutely right with the relationships. A lot of I saw some of the stats that were presented earlier. The stress from relationships with the father is contingent on some of the reasons for infant mortality, and a lot of these moms are in relationships that are not flourishing, that are not positive, that are not, and trying to get the father in is, you know, okay, well, there is no false, I don't want to send false hopes for the relationship, the father might be saying. So I won't be involved with your pregnancy or that kind of thing. So we spend a lot of time, to be totally honest, Calvin, dealing with supporting the moms to develop the sense of who am I, building up this positive morale in them, understanding who they are, and all about just the whole thing about, it's one thing that it would be awesome. We really would love to get the fathers involved, but it's also how do we support that angle of getting the father involved, understanding that it's not about a relationship with the couple as much as it is about the development of the child. And that's where that fine line is really challenging. And then keeping the mom healthy through this negative, not so positive relationship. And that's just one of the areas of relationship she's dealing with, not to mention family and other aspects of that support.
Yeah, and
I go to Mike Newsom. He's got a question or a comment, and he's in that same area.
Hey, Jane, I will definitely swing by and we can talk about how every pair of matters can help you in that endeavor. But I also want to, not to take us off too much of a tangent, but I also have to talk about the elephant in the room about some of these guys are not real sure that the baby is theirs. So as a 10-year child support supervisor prior to this, I have to put that out there, that they're not always just being neglectful or not wanting to step it up. You know, many of them do want to wait until that paternity test has been done to make sure that the child is actually there. So that's also a factor. But I will certainly connect with you sooner than later, Jane.
Great. And I'm really, I could go on and on. I really want to digress, but I will, Michael, thank you. I will reach out to you, and I'm just going to start developing and supporting and getting re-engaged in that area of working with the teen moms now in inner city Dayton in particular, and throughout Montgomery County. And it's my passion, as you can see, having been a teen mom is certainly something that that I really, I'm passionate about.
All right. Thank you so much, Jane. So we have about 4 minutes left, 5 minutes left. I'm going to go back to each of our speakers for a final thought so you guys can think about that. Before I do, each of the breakout sessions today has a raffle associated with it. And the way the raffle works is I ask a question, and the first person that can navigate back to the chat and get the correct answer into the chat. So to do that, you go back to Pathable, click on infant mortality session, and there's a chat there. And the question is, what do the letters A, B, C stand for in promoting safe sleep? What do the letters A, B, C stand for in promoting safe sleep? I know just about everybody knows the answer to that, so it's a race. But while you're doing that, Dana, do you have a final thought for us today?
Sure. I just want to once again say thank you for letting me learn with and from all of you. I think I hear this loud and clear frequently, and I couldn't agree more. And we're trying to figure out how to get out of our own way in so many cases. Reinventing the wheel is absolutely not the right approach in most cases. You all are doing this work incredibly well and are truly meeting the needs of fathers in your community. So really thinking through what is ODH and the state's role in general in supporting you all in doing that, and how do we learn from your best practices and your experience to figure out how can we scale, leverage, or incorporate that into our existing efforts. It doesn't have to be something new or something different, but us just figuring out how do we support you in doing what already is working. So thank you again.
Thank you, Dana. You know, I just want to respond quickly. During the last administration, we had a statewide active group of folks involved in engaging fathers in maternal child health. It was part of OCPIM. I was the co-chair of that. I would absolutely love to reconvene that group if there was a way to do that as an advisory group for your program. So think about it. We can talk. Kay, do you have any final thoughts? You're still muted, Kay.
That's a great segue. I was thinking, along with Dana, thank you so much for this discussion. It's been really valuable for me to listen in and think about the work that we're doing and how we can expand on it and do better. I'm also going to take a question back. Can we bring fatherhood representation into our home visiting consortium, our advisory council? It seems to me just bringing groups together to make sure that voice is always heard in the discussion will be important for us. And there are lots of opportunities, I think, in the work that we're currently doing to engage dads and to learn more and to just make families stronger, children healthier. So really exciting to think about the possibilities. Thank you.
Great. Thanks for being so open to that, Kay. And Calvin, do you have a final thought for us?
Absolutely. Just again, thank everybody for participating in this important discussion. Fathers too often in the maternal child health space are the marginalized other. And it's going to take all of us in the community, at the state level, as the marginal, as people who are empowered to help fathers come into this space. And it needs to happen at the fatherhood program level all the way up. So we got to acknowledge our biases. We got to acknowledge ignorance. We got to acknowledge the fact that we need to aid and support men to have a stronger presence in maternal child health.
Right. Great way to close, Calvin. So thanks to everybody for coming today. Thanks to our three presenters for doing such a dynamic job. I can't remember what is next on the day at a glance agenda, but you guys can find that when you go back to Pathable. Please stop in the infant mortality session room there and add some more thoughts to the chat. So we have those going forward if we want to make some connections. So thanks again, everybody.
Steve, who won? Who won, Steve? I
haven't been there yet. That'll be announced at the end of the day in the final session. Okay. End of the day, final session. I should have said that. You thinking you got it, Robert?
He must be thinking that.
You must. Let me go check now.
Did not. I did not.
Did you see?
I did not win.
Who did?
Oh man.
Right?
It was dang, I forgot her name. That quick. I'm old. But I think it was a young lady in this group. It was a young lady. It wasn't one of us.
Looks like Alex beat everyone out for the win.
Who was it?
Alex, and I'm so sorry, I'm going to butcher your last name, Paquette. But she was the first to chat in with the ABCs of safe sleep, staying for
on
your back and in a crib.
I haven't found it yet, but I'll get there. Get that back to the. I'll take it to the main session at the end of the day, Alex, and you'll get a prize.